to Dr. John Maher. Earlier this week at our hearings, we had one witness who advocated for including mental illness as a sole condition in MAiD eligibility, referred to pre-study testimony from Dr. Raji from CAMH. Dr. Raji had testified this, quote, "Some of the longitudinal studies show that 30% of people go into remission, 30% stay the same, and 30% get worse," quote. But Dr. Maher, for someone advocating for MAiD to consider that the 30% of those patients with mental illness who, quote, get worse, equates to those mental illness patients who meet the irremediability requirement for assisted suicide, I think that's incorrect. Many people with mental illness who get worse also later get better, and I'm privileged to know some of them. So, Dr. Maher, could you please tell us more about that and the difficulty in determining the significant hurdle of irremediability in mental illness cases?
Certainly. Thank you very much for the question. Let me answer the question by building on what Dr. Iguarta just said. She said there was significant consensus in Quebec. Their survey for their report heard from 263 of the 1,300 psychiatrists, and about 40% of those said they would never support MAiD in any conditions. And another 40%, don't know if it's the same 40%, said that you can't determine irremediability for at least 10 years. That's a long time. And this is from a small sample. And the only Canadian sample we have of psychiatrists goes back to 2016, before any of the Canadian psychiatrists had a full sense of what this would look like if fully operationalized. And at that point, 75% said no MAiD for mental illness. So that very significant disagreement within the psychiatric community counts for something. And there is no consensus. And back to the point of studies that you're asking about, studies they involve a small group of people over a set time period with a very specific intervention. It is absolutely impossible to extrapolate from any study data, even long-term prospective data, to the particular individual in front of me. I don't know whether they're going to be in the category of people who statistically don't get better or the category that do. And I'd also refute some of the data that I've heard at these hearings. Transcranial magnetic stimulation, for example, TMS, a non-invasive procedure. At this point, the latest data is it's 90% effective for people with treatment-resistant illness. So when I hear something like a sunset clause against a backdrop of treatments improving steadily, and against the backdrop of absolute uncertainty and absolute clinical inability in this moment to sort out whether this person will get better. And also, we don't know the duration, we don't know the time. Time itself can be healing over and above all the other interventions.
Thank you.
And when I hear learned psychiatrists like Dr. Stewart say there's no distinction between mental illness and physical illness, and then goes on to describe the overlap between the two as a way of showing the distinction. You know, I put my logic hat on here, and I have to express my frank concern with an oft repeated statement. We can do capacity assessments, we can sort out, people with physical illness who need MAiD, therefore we can do it with mental illness. It's what in Logic 101, you call that a category mistake. It's focusing on what is the same rather than what is different. And yes, you can have capable people no matter what their illness, no question. But I'll use an analogy that's used when you're trying to explain why this doesn't make sense. Say I've got a Walmart parking lot and everybody drives in, and my working assumption is they've got mobility, they got into the parking lot, and I say they can get to the store. But I'm not taking into account who has a walker, who's in a wheelchair, who is pregnant, who has impaired mobility, right? So by focusing on the similarities, when I hear lawyers in particular say, this is discriminatory to say these people can't make their own capable decisions. The discriminatory piece is actually ignoring the differences. What it amounts to is the privileging of an equity argument over an equality argument. And what is that? Because it's said over and over here. Equity, we all should have access to MAiD. That's basic playground fairness. Well, let's look at the playground. If I have a teacher come out, she's got a bag of candy for all the kids, everybody should get one. That's fair. That's an easy sell. But what about the kid who has diabetes? What about the black girl who's in the corner, who's afraid to come forward because of the racism that exists on that schoolyard? Equity is access. Equality is actually looking at what matters for a human being to heal, to thrive, to live. And because this is a charter issue, it really frustrates me that when I hear lawyers take an equity focus over an equality focus, because that is the legal issue here. That is the legal issue.
Thank you. Senator Plitt.
Second round, if there is one. Thank you.
Senator Plitt.
Thank you, Chair. Dr. Mayer, if I could just continue a little bit, and please give me a not too long of an answer, because I do have one for Mr. Hurwitz as well. But I want to continue along what Senator Batters raised. Jocelyn Downey and other assisted suicide advocates, including some that we heard here today, have suggested that excluding mental illness from this regime is discriminatory, and you have said it isn't, and thank you for that. Can you explain to me why there is such a strong disagreement amongst psychiatrists on the inclusion of illness for assisted suicide? You've obviously all taken pretty much the same training, so on and so forth, and yet there's a distinct difference in opinions. Is there any way of explaining that in a few words?
Certainly. The quick answer would be the nature of the work you do, the degree of clinical experience and acumen you have. And there aren't a lot of psychiatrists who work in specifically the intensive care field that I do, with wraparound care, who know what's possible. I worked in outpatient psychiatry. I worked in a personality disorders program. I've done all that other psychiatry stuff, but I didn't know what was involved with good wraparound supportive care over the long term that is proactive. 70% of people who have serious mental illness don't take their medications. The majority refuse treatment, even when it's available. A large majority of my patients do not believe they have a mental illness. They are relying on us to help them get well when they can't do it themselves. So why is it so different? I mean, some of it, of course, is values. I worked with a psychiatrist colleague. I loved him, and he encouraged people to commit suicide if things weren't too good. And then he ultimately killed himself. There was a value piece that drove him. But as we've heard, that's fortunately a rarity, right? We are by nature, I think, self-selected as optimistic, hopeful people, doing our best to bring comfort. But there's burnout. There are psychiatrists who give up. I wouldn't want to disparage colleagues, but I certainly have colleagues who, when they refer patients, they feel they've tried everything. And I look at it and I think, wow, there's a whole lot that hasn't been tried. And that's true in any area of medicine.
Thank you.
Thank you.
No, thank you very much. And Mr. Hurwitz, if I could, please, given your amazing results in reversing suicidality in patients, can you elaborate on the safeguards that are in place presently in regards to assisted suicide and how that would compare with the safeguards proposed in Bill C-7?
Well, I can just tell you about the safeguards we have to get capsulotomy. We have 2 psychiatrists assessed for the fact they have treatment-resistant depression, and they have had to undergo all available treatments, including 2 courses of ECT, all antidepressants, including a monoamine oxidase inhibitor. They've had to have psychotherapy, so they have to be truly treatment-resistant, and they've got to be suffering terribly. Once they've met 2 psychiatrists, we send them to 2 independent psychiatrists to assess that they've got capacity, because our ethics committee was concerned that their suffering would so shape their thinking they'd do anything to get relief. Then they go and see the neurosurgeon. Then we send reports to a lawyer. The lawyer meets with the patient. Then the patient, that committee gets together, and when the committee decides, those individuals are then eligible for capsulotomy. So because of those stringent criteria, We have had 12 patients in 22 years that have come through for treatment-resistant, unbearable suffering. And if 10% of the population of the population have depression, that'd be 500,000. And 10% are treatment-resistant. We should have had 50,000. And 50,000 people have not come our way because our treatments are very successful to stop unbearable suffering. When I see the safeguards currently in place, they don't even come close to the safeguards that we've got in place to do a procedure that would save a life. And this is a safeguards that are going to take a life.